So yeah, thanks for inviting me. My intention was to talk about head injuries and the pre-hospital management and assessment of these. It's really difficult doing these presentations this sort of way because I can't see any of you. I can't see any hands going up. I can't see any facial expressions or anything. I'm literally just looking at a PowerPoint. So it's hard to gauge kind of how interested you are or any questions or anything like that. So if there are questions, please feel free to speak up and ask them as we go along, or there'll be an opportunity at the end to ask some questions if that's helpful. Yeah, so we'll keep it fairly informal. Like I say, speak up if you want to, and maybe Jacob or Carolina, if you see people putting their hands up and things, just butt in and grab my attention. So I say thanks for the invite. I'm an A&E consultant. Yeah, A&E, not emergency medicine because I'm old, and pre-hospital emergency medicine, and I do a few other bits in pre-hospital care up and down the country and predominantly in Yorkshire. Anything I say tonight is kind of my opinion. It's not necessarily the opinion of any of these organisations. And the other disclaimer is that head injuries are a bit of a pet subject of mine, so I can get a bit geeky. So some of the slides I'm aware have gone a bit scientific and a bit geeky, so I apologise about that, but hopefully it's useful and we'll all pull together towards the end of the talk. So what I wanted to do is just cover the pathophysiology and the management of head injuries in the pre-hospital environment. We'll talk about minor and major head injuries and some of the differences there. We'll just review some of the very basic anatomy, some of the very basic physiology, think about some of the types of injury. And then what I really want to focus on at the end is treatment to minimise secondary brain injury. And you'll hear me talk a lot about secondary brain injury and how we can minimise that, because that really is the key thing that we're trying to achieve when we're managing these kind of injuries in the pre-hospital setting. So I don't really apologise for repeating that a lot. So firstly, what is a head injury? A head injury is anything from a very minor bump to the head right through to really significant, not compatible with life injuries. And we have to think about any other injuries they may be associated with, which can be anything on the whole body, but we particularly have to think about neck injuries and cervical spine. We need to differentiate what is a minor head injury from a major head injury. And we need to, as I said, limit secondary brain injury. And that really, for a major head injury, that is the key thing we're trying to achieve, limiting secondary brain injury. So we'll focus on that. It's a significant problem. 1.5 million people present to the UK emergency departments each year with a head injury, half of which are children. So you'd imagine they're all the significant head injuries, but there are going to be a lot more minor head injuries as well that never present. So it's a big problem. And about 5,000 people die from TBI each year in England and Wales. So that's a big number. 1,500 will survive brain injuries, but have severe permanent brain damage. So these are massive numbers, and this has a massive impact on society. It's huge. So this is something that we need to look at. We probably can't impact on the number of people that die. So that's going to come from safety strategies, road safety strategies, improving safety mechanisms in cars and so on, which a lot of work is being done in that area. But as pre-hospital clinicians, we focus, as we said, on the secondary brain injury, and that's going to impact on partly it will impact on mortality, but predominantly it will impact on morbidity. So how severe people's brain injury is and so on at the end. So that's where we're really focusing. As we might expect, the majority of head injuries or severe head injuries are relatively young men. Most of them come from road traffic collisions. So this one here, Hambleton, Selby, this was a pedestrian knockdown last week that I went to, who had an isolated, no, she didn't actually, but the major injury was a severe head injury. Assaults are very common. So that can be a severe assault that leads to a severe head injury, or it can be a single one punch. You'll have heard about that, one punch fatalities. It isn't usually the punch that kills somebody, but when somebody falls over and hits the head on the floor, that causes the severe brain injury that kills somebody. And I haven't mentioned it in this talk, but you can get something called impact brain apnea, which from just one blow to the head, a patient can stop breathing. And that's often a temporary thing. But if in that period where they're not breathing, they become hypoxic to the point that they go into cardiac arrest, then that impact brain apnea can be fatal. So you'll see that a lot with motorcyclists as well. And often getting to one of these people and just opening an airway breathing for a short period. That will get them through that impact brain apnea, and that will keep them alive. Falls, sporting accidents, and industrial incidents are the key things where people get these severe head injuries. So why is the brain important? The cerebrum, that's the main bit of the brain that does movement, speech, all of our higher thought processes and so on. Clearly that's important, and damage to that will have huge impacts. The cerebellum, the little bit at the back, that is balance and fine coordination, etc. So maybe not quite as important for our bigger, higher functions, but certainly very important from being able to live a normal life. And then as we get a bit lower down, we've got the brain stem, which has the reticular activating system, which is important for consciousness. And then a bit lower down, there's the medulla, which has all of our breathing and cardiac function centers. So all those bits are really important, obviously, it goes without saying. If we think about our physiology, the brain has got a very high oxygen demand for its size and a big metabolic demand. So it needs a high oxygen supply, it needs a good blood supply to keep all of those things working properly. It can't regenerate itself if it's damaged, like some other tissues can. And the brain has brain tissues have different densities. And what that means is if you get a big deceleration, parts of the brain will carry on moving while some of them have decelerated, and that causes a big shearing effect that in effect can tear some of the brain tissue, which obviously is damaging. So we need to ensure when we're thinking about secondary brain injury that enough oxygen and enough blood are getting to the brain. That's really important. So we'll keep that in mind. Thinking about very basic anatomy, the skull is a big box that is designed to protect the brain. It then has a few layers around the brain. So the dura mater, the arachnoid layer, you'll know all this better than me. You've done your anatomy more recently. But these provide a protective covering to the brain. When you get bleeding, you can get bleeding at any one of these levels. You can get one outside the dura, extradurals, below the dura, subdurals, below the arachnoid space, subarachnoid bleeds, and you can get bleeding into the brain tissue, intracerebral hemorrhage. Different kinds of different age groups, people with different comorbidities, they're more prone to different types of bleeding. So it's a useful academic exercise to know what's happened, but really in the pre-hospital setting, it doesn't really matter what kind of bleeding they've got. It's just there's brain injury and bleeding. That's all we need to think about. A really important phenomenon to think about, we need to just be aware of, it kind of sounds more fancy than it is, the Monro-Kelly doctrine. It's a really basic idea. It says that the skull is a fixed box with a fixed volume, and usually about 80% of that is filled with brain, about 10% is blood, and about 10% is CSF. And it normally stays in that sort of homeostasis. If we change that, so that could be a tumor, but for the purposes of tonight, we're thinking about extra bleeding, so a big bleed, and that's what the mass is. The mass there is blood, which isn't normally there. What will happen is it can expand to a degree and it can tolerate that little bit of extra volume to a degree, but then it will get to a point where something has to get pushed out to accommodate that extra mass. And to start with, extra blood and extra CSF will get forced out, but it will reach a point where the brain starts getting squashed. And that then is a kind of critical point. So we need to minimize bleeding, we need to minimize swelling to limit how much the brain is squashed. So like I say, a fairly basic concept. Monro-Kelly sounds more fancy than it is, but we just need to kind of bear that in mind. So when we think about head injuries, there are not minor and major. There's a spectrum of injuries that run all the way through. But for the purposes of tonight, we'll just think about minor head injuries and major head injuries. So minor head injuries are usually concussive type injuries. And we'll have all seen these when we're watching sporting events, or we may well have all been concussed ourselves if you've played sports or done anything like that, right through to major non-survivable head injuries. So if you think about concussion to start with, because I think this is something which is not very well understood, what this is a group of symptoms which are seen after a head injury, but there's no macroscopic brain injury. So if you look, there's nothing to see on a CT or anything like that. But actually, if you delve into this to a cellular level, we're starting to find more and more there are injuries which are happening to the brain at that microscopic and even smaller level. So there is an injury which is going on with concussion. So it perhaps isn't as minor as we often think it is. There's a very arbitrary grading system for concussion, so mild, where there's no loss of consciousness, and a transient disturbance of your neurological function. So you get a bang on the head, you might be a little bit confused or disorientated or have a headache, something like that. And you might develop a bit of post-traumatic amnesia, but that will usually be less than 30 minutes. So that's a mild concussion. Moderate is as above, but with a loss of consciousness less than 5 minutes. And you might have retrograde and anterograde amnesia. A severe concussion is where there's a loss of consciousness more than 5 minutes, longer period of post-traumatic amnesia, and a much higher likelihood of what's called post-concussion syndrome. So that's an arbitrary grading system of a concussion. Post-concussion syndrome is where you get a long-standing neurological deficit or symptoms after the injury. So most of the time, concussion will settle down pretty quick. But if you get post-concussion syndrome, you can end up with a constellation of symptoms which can carry on for a long time. And this can be weeks into months. And that can be anything that's listed there. So dizziness, depression, poor memory, problems concentrating, poor coordination and fine motor coordination as well is a common symptom which people get. And it can be very disabling. So I know when I used to look after a lot of rugby teams, I know at least one professional player whose career was ended with post-concussion syndrome because he just lost his fine motor skills. So it can be very disabling. So it's really important that we treat concussion properly early on because that reduces the risk of a post-concussion syndrome. So rest is really important, and that's not just physical rest, that's resting the brain. So somebody with a severe concussion, they need to rest their brain. That means no work, no school, no activities like going to the gym or doing anything stressful or anything that's going to cause them to use their brain effectively. They need to stay well hydrated, and that means no alcohol, no caffeine, that sort of thing. And then they need to follow a graduated return to activity. And what I've put on here is the Rugby Football Union return to play programme, which players have to follow. The other thing which you may see, which I haven't actually put on here, is there's some thoughts that high flow oxygen immediately after the injury will reduce the risk of post-concussion syndrome. So again, if you watch, for example, rugby on the telly, I'll keep coming back to rugby because it's the sport I know about, but I'm sure other sports are similar. But if you see players on the telly who've been concussed or come off for a head injury assessment and not got back on, you'll often see they're sitting there breathing some oxygen. And that's because that's thought to reduce the risk of post-concussion syndrome after a concussion. We also need to think about second impact syndrome. So what that is, if you've had a minor head injury, so a minor concussion, there are some thoughts that affects the auto-regulation of blood flow around the brain. And then if you have a second minor head injury, the effects of that are much larger than they should have been. So you're much more likely to get severe head injury after a minor head injury, if you see what I mean. And that's why people are so specific about needing return to play programs like the one I've just put up for rugby. So you need to follow those return to play, you need to be symptom free, and you need to be cleared to go back to these sports. And that's both, like I say, to make sure that there's not a risk of getting more concussions, so one after another, but also to reduce the risk of second impact syndrome, and also to make sure that you're fit to return to the sport, because if your coordination and stuff is still off, you're at risk of other injuries. So we need to think about post-concussion syndrome, we need to think about second impact syndrome. A lot of that is very specific to sport, so I'll come away from that and just think about how do we assess a minor head injury. So we're still going to use our ABCDE approach, which I'm sure you're all familiar with, and I'll go into in more detail later on. But we need to make a thorough assessment of that patient to make sure we're not missing any other injuries. Consider the mechanism. What exactly happened? Was it a very minor bang on the head, or was it something we should expect to cause a serious injury? And consider, have they got other injuries? So, for example, could they have a neck injury if there's been a clash of heads playing rugby or football or something like that? We need to think about what criteria might there be for somebody to be discharged from scene and discharged home. And that would be things like they haven't had prolonged loss of consciousness, they haven't had a fit, they haven't been ataxic, they haven't had any tonic posturing, there's somebody sensible at home for them to go home with, your judgment of the situation isn't clouded by them being intoxicated or anything else like that. So a whole bunch of criteria which need to be fulfilled. And we need to make sure we've advised the patient and whoever's going to be with them all the red flag things to look out for. And I'm not going to go into that right now because that's outside the realm of this. But I think the basic thing to say from a pre-hospital environment is if you're any doubt at all about a head injury, refer them in. And then that means that in the ED, we can do a CT scan if needed. But what it also means is they're going to have a period of probably several hours while they're waiting to be seen. And whilst that feels like it's a waste of time, it isn't, because that is a period of several hours where in effect they're being observed. And if any major head injury symptoms were going to develop, it will be apparent to us at the time. So if you're experienced, confident and competent, you can discharge some head injuries from scene. If you've got any doubts, refer them into the ED. Okay, so hopefully that kind of covers minor head injuries and things to look out for. That's just a bit of an introduction really to the evening, so don't worry too much about that. If we just start thinking about major head injuries, I want to think just briefly about scalp injuries, a little bit about skull fractures, and then I want to focus really on brain injuries because that's the key of what we want to talk about. As Maggie from The Simpsons here says, basics are best. So I thought I'd just put a little basics flag on there, a little shout out to basics. I'm not sure whether you all know what basics are, but anyway, asking the questions if you don't and you're interested. There we go. So scalp wounds are usually really impressive because they bleed an awful lot. The scalp has got a really, really good blood supply. So like I say, it bleeds really impressively. So we need to get control of that, and it will usually respond to direct pressure. And often if you press on both sides of the wound and push them together, you can get pressure from the wound edges coming together. So that usually will work really well, and that will usually stop the bleeding. If you can't stop the bleeding by doing that, or you need to actually just get control so you can move on to do something else with the patient, you can chuck a couple of big sutures in, or even just some staples, and get control of a big wound that way. So yeah, that's scalp wounds. They bleed a lot, get control and move on. Skull fractures are, if someone's got a very obvious skull fracture, it's usually obvious. There's usually a big depression in the head, or there's a big wound over the top and you can see or feel the fracture. And that in itself is not a problem. The skull is just a box, it's just a bit of bone, and it's designed to be there to protect the brain. So often, if the skull is fractured, it's taken the force of that blow, of that injury, and it may well have stopped any energy being transferred to the brain. So whilst the skull fracture is significant, it doesn't mean there's necessarily an underlying brain injury. But obviously, it's an indicator of force that's happened. So we do need to take that seriously. And obviously, if there was suspicion of a depressed skull fracture or an open skull fracture, that patient has to go to hospital immediately for us to do a CT scan and see what's going on. Another type of skull fracture that you may come across is a base of skull fracture. And the way that will become apparent, usually in the acute setting, is there'll be a CSF leak. So there will be a sort of straw-coloured fluid coming from the ear or coming from the nose. It'll often be stained with blood, so it can be difficult to tell, is this a nosebleed or is it bleeding from another wound? But often it's quite apparent. So if there's any suspicion at all of a CSF leak, that patient needs to go to hospital for further assessment. The other thing that you may see are what's called raccoon eyes and battle sign. Now, these are both late signs. You're not going to see these necessarily in the acute setting. Raccoon eyes, that's different to a black eye because you've got all of that bruising above the eye, which you don't usually see with a black eye. And battle sign is just bruising over the mastoid, which again, if somebody's been punched on the mastoid, you may see that anyway, but often they haven't, and that bruising will come out, and that should make you very suspicious of a base of skull fracture. So if you see a patient maybe a day or two after an injury that's got these, they need to come into the ED for further assessment. So I want to just move on. I want to just start to think now about brain injury, and there's a concept which is really important, which is primary and secondary brain injury. Primary brain injury is the injury that occurs at the time. So bang, there's an impact and there's damage done to the brain. Now, the main bit of that is because, so you may have a penetrating brain injury, so there's something that's gone through the skull into the brain. You may see that, although that's less common. It's usually a blunt force. So, and we're usually talking about a rapid deceleration. So that's what causes the problem, is that the skull stops and the brain keeps moving. So you may get bruising at the front of the brain where it's hit the skull, but then also as the brain bounces back, it hits the other side and you get what's called a contre-coup injury. So you get that kind of bruising to the brain, those contusions. But also, as we mentioned earlier on, because some of the brain tissue is different densities, it will keep moving at different speeds. So you get a shearing injury within the brain. So that can cause bleeding, but it can also cause something called diffuse axonal injury, which is harder to see on CT, but actually can be fairly catastrophic. But those are things that we can't impact on. That happens at the time of injury. And short of being involved in sort of road safety and sport safety and so on, we're not going to make a difference to that. That's a different group of people that are targeting that. What we can impact on is secondary brain injury, and that is the injury or the damage which happens after that initial impact. So that is usually related to not enough oxygen and not enough blood getting to the brain, and that is often due to bleeding and swelling around the brain. And that's really where we're going to target our care, is trying to minimize that. So as we said, secondary brain injury is related to hypoxia, it's related to hypotension, so not enough blood getting to the brain. It's related to a raised intracranial pressure, so the pressure in the skull is too high to allow blood to pump up into it. It's related to your blood sugar being high or low, and it's related to your carbon dioxide level in your blood being too high or too low. And as we said, the treatment is focused on brain injury. If we just look at this scan, if we come back to the Monroe-Kelly doctrine, you can see on the right side of the scan, there's the big bleed, that big white bit. But importantly, you can see that the midline of that brain is being pushed over to the left. And so there's raised intracranial pressure in there, and that's going to cause some damage to the brain and some secondary brain injury. This chart, it's a little bit complicated, but it isn't really. If we follow it down from the top, head injury, and come down to the left, it will cause ventilation problems. So you've got your, if you've got an airway occlusion from your head injury, you've got a reduced conscious level, you block your airway, or you're not breathing properly, that will cause hypoxia, which causes cerebral hypoxia, which causes brain injury. It causes the brain to swell, the intracranial pressure goes up, you get reduced perfusion of the brain, and you become more hypoxic in the brain, and it's a vicious circle that goes on. Likewise, the head injury will cause direct brain injury, which will cause the brain to swell, which causes the increase in ICP and around the circle. Same with intracranial hemorrhage. You also will get other injuries from major trauma, which will make the patient go hypovolemic, which will cause reduced perfusion of the brain and just global hypoxia, which feeds into the cerebral hypoxia. So it's a bit of a vicious circle, but you can see hopefully how head injuries just have got this vicious circle going on. And so we need to intervene to minimize that hypoxia, to minimize the hypotension, and to minimize that increase in ICP. If we just think about the ICP for a second, this is a brain. The map is the mean arterial pressure. So this is the patient's blood pressure that's pumping blood up into the brain. It's balanced by the intracranial pressure, which is the pressure in the head that's pushing down. And the product of those two is the cerebral perfusion pressure. So the cerebral perfusion pressure is the pressure pushing up minus the pressure pushing down. And usually the brain will auto-regulate to keep that cerebral perfusion pressure exactly where it needs to be. But if you get a drop in your map, if you get a drop in your blood pressure, you can see the cerebral perfusion pressure will also drop. Or if you get a raise in the intracranial pressure, that will also cause the cerebral perfusion pressure to drop. So it's very important that we keep the map up and we keep the ICP down. And by doing that, we'll maintain that perfusion pressure to the brain. So that's a lot of what we're talking about, what we're trying to achieve. If the brain is put under pressure because the intracranial pressure goes up, it compresses a lot of the vital structures that we spoke about. So particularly I'm thinking about the respiratory and the cardiac centers. So when you get a raise in pressure, those things get knocked off. You don't get enough blood flow to the brain, you don't get enough oxygen, you're therefore going to build up a waste products, the brain swells, the neurons start to die, and then you start to die. So it's not good if the brain's put under this kind of pressure. So if the ICP rises, you get, like we said, you get reduced cerebral blood flow, reduced oxygen delivery, cerebral vasodilatation. And when you vasodilate, you cause more blood to go there, so you will bleed more. And it's just a bit of a vicious circle there. And as the cerebral blood flow falls, your synapses start to dysfunction, your sodium potassium pumps stop working, and that leads to cell death. And that's all really bad. So by intervening early in the pre-hospital setting, we can impact on all of these things. And so a lot of the very basic things that we do might seem very basic and boring, but what they're doing is they're stopping the map from falling and they're stopping the ICP from rising. So we're having an impact on this brain injury. So how are you going to recognize a raised intracranial pressure? The patient will almost certainly have a reduced conscious level. They may have a reduced respiratory rate. They may have a reduced pulse rate. They may have a high blood pressure, but they may have a low blood pressure. And what you often see is a very fluctuating blood pressure. So 1 minute it's really high, next it's really low. They may also have either a unilateral or bilateral fixed and dilated pupils. So those are things that we can look for. In terms of pupils, people get very, very excited about pupils. But when you get a fixed dilated pupil in the context of a head injury, it's really obvious because the patient isn't sat there talking to you because they've got all this other stuff going on. So they're usually unconscious with all the other stuff we just mentioned. And you get a fixed dilated pupil because of this. There's a lot of words here, but it's basically, it says that as the pressure in the head starts to build, it presses on the brain, and the uncus, which is a little bit at the bottom of the brain, it presses down and it compresses the oculomotor nerve. And the oculomotor nerve is the one that controls the pupils. That can't send its message, so the pupil goes to its fixed dilated state, which is kind of its natural state, because the nerve tells it to constrict. So that's what you get, and that's what we see here. It's just that the uncus, it starts to herniate down and compresses the oculomotor nerve, and that stops the pupil being able to constrict. So that's why a fixed dilated pupil is significant. However, there are many, many other causes of fixed dilated pupils. You can see a difference in up to 20% of the population if you look, and more than 5% have got a much bigger difference. The difference with those people is their pupils will be, they'll react normally to light. So in a trauma, it'll be unreactive, it'll be fixed. But in a population where it's just normal, it will respond normally. In a trauma setting, you can also get what's called a traumatic mydriasis. So this is somebody who's been punched in the eye or got a squash ball to the eye or something like that. And in effect, there's a bit like the muscles around the eye, the ciliary muscles become very sluggish. So there will be a difference in the size of the pupils. And when you shine a light in the eye that's affected, it will be sluggish in its response, but it will respond. And that's the difference between a traumatic mydriasis and a true fixed and dilated pupil. A fixed dilated pupil will not respond. Some drugs can cause pupils to be dilated. So if somebody's taken something in a nightclub or whatever it might be, they'll both be dilated. Or if they've rubbed their finger into an eye with something, that may give you unilateral. But again, they won't usually be unconscious with all of the other stuff that we mentioned. Also think about trauma. There's something called Horner's syndrome, which has got several causes, but from a trauma point of view, if you damage the sympathetic chain, you lose that sympathetic input, and therefore you get a meiosis. So one of the pupil becomes dilated, the other therefore will look dilated. But again, that will react normally. So there are ways to tell the difference between a proper trauma fixed and dilated pupil and some of these other things. So I want to just come on to think about how we're going to manage head injuries and go through the CABCDE thing. And as I've said several times, what we're trying to do here is preserve life, so keep the people alive till they get to hospital, and minimize secondary brain injury, because that period immediately after the injury is crucial. So, you know, if the patient's going to be an hour before they get to hospital, which sounds a long time, but it isn't, then for that hour, we need to do what we can to minimize that secondary brain injury. And it is basic stuff, as we'll go through. So firstly, if there is any catastrophic hemorrhage, we need to control it. And that's important because if we don't, that mean arterial pressure will drop, which means the cerebral perfusion pressure drops, which means you get all of the negative things that we spoke about. So something as simple as putting direct pressure on a big wound or controlling that scalp wound or whatever it is, something like that can save the life. Okay, it doesn't sound very exciting and all that kind of stuff, but it is. It'll save a life. So control catastrophic hemorrhage. We need to think about the airway. If the airway is occluded, we need to open it somehow. And there are very simple ways to do that with a jaw thrust, or if we need to do a head tilt chin lift, then we need to do that. But simple maneuvers can open an airway. If we've got them with us and we've got the skills and the experience, we can use simple adjuncts like nasopharyngeal airways or oropharyngeal airways to open the airway up. And if we have the stuff with us and we've got the skills and experience, and ideally some drugs, we can use advanced adjuncts. LMAs, I don't think anybody has anymore, but certainly eye gels and endotracheal tubes, so formal intubation. And if necessary, we can proceed to surgical airway. It's also important to suction an airway if we can to keep some blood out of it. But again, doing a jaw thrust and suctioning some blood, it might not be the most exciting high-tech thing in the world, but it will save a life. It will reduce morbidity. So basic things like that are really important. Managing an airway is important. If we're going to go on to our advanced airway things, so by that I mean eye gels and formal intubation, we need to be very, very careful what we're doing if we're not using any drugs, because there's a risk if the patient isn't completely flat, we may cause vomiting, which they'll then aspirate, which causes pulmonary and ventilation problems. We may cause laryngospasm, we may cause a surge in that intracranial pressure, and we may cause bradycardia. So we may inadvertently make things a lot worse by advanced airway management. So ideally, you'll have somebody there with some drugs that can manage that airway properly. Cervical spine. So yes, we need to remember C-spine and we need to get control as soon as patient contact is established. But I will caveat that with, if you're by yourself and you need to open an airway or do something else immediately life-saving, that probably should take priority. But having said that, there will often be bystanders or people there that can just hold the head still as best you can. During airway manoeuvres, we need to manage that C-spine as best we can, because there's a risk that we can hyperextend the neck and do all sorts of things with it. So that's the neck. Moving on to B, we mentioned here that we need to avoid hypoxia and we need to maintain a low normocapnia. So hypoxia speaks for itself. You need plenty of oxygen to be going to the brain. So if there's not a lot in the blood and there's not that much blood going to the brain, that's not a good situation. So you want as much oxygen in the blood as you can. And if we're going to ventilate the patient, we want that carbon dioxide level to be at a low normal, so sort of 4 to 4.5 kilopascals. If your CO2 goes very low, you vasoconstrict, and so that means not enough blood is going to get to the brain. If your CO2 is too high, you'll vasodilate, and that will cause more bleeding. So it's really important to control that carbon dioxide. So we're going to manage, or we're going to achieve those two things by assessing and treating for any life-threatening chest injuries. So if there's a tension pneumothorax, an open pneumothorax, massive hemothorax, a flail, we're going to manage those conditions to allow that patient to ventilate as well as possible. It might be that they still need support of that ventilation, and we can do that with a bag valve mask or a pre-hospital emergency anaesthetic, which we'll talk about in a sec. Pretty much any serious head injury is going to get high flow oxygen through a non-rebreathe mask. So that's how we manage breathing. Circulation, we've mentioned it a few times. We want to maintain that mean arterial pressure, which maintains the cerebral perfusion pressure. And so we do that by stopping bleeding. We've mentioned it. Like I said, it's not exciting, but it will save lives. Stop bleeding and then maintain any circulating volume. So we might want to put some traction splints on or a pelvic binder, which will help control bleeding, as well as the tourniquets, direct pressure and hemostatic agents. But also we might want to think about circulating volume. So there are guidelines there about fluid resuscitation in trauma, and a lot of that is about permissive hypotension, because if you've got thoracic or abdominal or pelvic injuries, you don't want to throw in loads of fluids and dilute down the blood and dilute the clotting factors and affect the acid base and make them cold and do all that kind of stuff. And also, if you put the blood pressure up too quick, they'll start bleeding again. But if the patient's got an isolated head injury, those guidelines don't apply, and we need to be aggressive at keeping the map up. So we would think about blood products, so packed red cells, plasma, and FFP, FFP if we have them with us, or normal saline if we haven't. And there may well be a role for hypertonic saline in a severe head injury, particularly if there's evidence that they're starting to cone. Hypertonic saline may just buy us a bit of time. So stopping the bleeding, maintain that circulating volume, will maintain the map and maintaining CPP. When we get to D, the whole thing is about D, so there's nothing specific here, but when I'm going through my primary survey with patients, this is my place to start thinking about other bits we can do. So I would lift them so they're about 15 to 20 degrees head up, and that just helps venous return, which again reduces that ICP a little bit. I've said loosen collar. To be honest with you, most of these patients don't have collars on these days. The jury is still out about whether we should be using collars or not, and there may well be consensus statements coming out before too long. But certainly in somebody that I have anaesthetized, I won't put a collar on. I'll still have blocks and tape, but I don't have a collar. And that is because if there's a collar on, you can't easily get to the airway to do anything with that if you need to. But also it may, if it doesn't fit well, you will impede venous return, which increases your intracranial pressure. The other thing we find is if the patient hasn't been anaesthetised, having a collar on often increases agitation, and that will make them harder to manage, but it will also increase the intracranial pressure. So collars have a role, but maybe not all the time. We need to think about analgesia because these people have got, a nasty injury and they're going to be in pain, and that will cause the blood pressure to be up. So we need to think about analgesia. As we mentioned, we need to be cautious about unanaesthetised advanced airway interventions. Think about hypertonic, ventilate them down to low normal carbia, and prevent hypoxia. The other thing that should be on there is just check their sugar. So those are the things that I think about during D. And when we get onto E, it's just checking for any other life or limb-threatening injuries, splinting, fractures, all the other bits. The one thing I haven't mentioned on here is TXA, so tranexamic acid. There is a role for tranexamic acid in isolated head injuries, so they would also receive that. Then finally, we need to take them to the most appropriate place without delay. So if we've anaesthetised somebody, intubated and ventilated them, then we can bypass to the most appropriate neurological centre or neurosurgical centre. Even if we haven't, we still may well be able to safely bypass to one of those centres. But if we haven't got anaesthetic capability with us, we may need to go to a trauma unit to get the patient intubated and ventilated before moving on to that neurosurgical centre. Just a little bit about pre-hospital anaesthesia. So it's a great thing to be able to do. It allows you to secure the airway, control that ventilation, which means you can keep the oxygen levels good, and crucially, you can manage the carbon dioxide. It takes away any pain, it manages agitation, and that allows you to transfer the patient nice and safely to hospital. There are risks with it. There's a risk of hypoxia during the intubation phase, and even one dip of hypoxia will have a significant impact on morbidity. There's a risk that if we can't intubate and can't ventilate the patient, then actually, they may die from that. So it's not something to be taken lightly. And also we need to think about the hemodynamic effect of the drugs, because there's a significant effect of causing a drop in the blood pressure, or if we haven't given enough, of causing a surge in the ICP. So actually, we may have negative impact on the morbidity if we get our anaesthetic wrong. So it's not something to be taken lightly. You need a well-drilled team to be able to do it. You need robust processes and SOPs. So you need a SOP to follow that everybody's going to follow, but also you need governance processes afterwards to review all of the interventions that we've done to make sure we're doing it properly and to identify any learning which we can share. Sometimes a good team will still choose not to do an RSI. RSI is rapid sequence induction. It's the same as an anaesthetic. And that might be if you're on the doorstep of a hospital. It might be if it's an obviously really, really difficult airway that you're going to run into trouble with. You may be better to scoop and run to a place of safety where that can be done. So, but also just looking at the makeup of the team. If you're not experienced or your colleague's not experienced and things, all these factors will come into play that will help you decide whether or not you're going to do an anaesthetic or not. If we do one, usually the drugs will be fentanyl, ketamine, and rocuronium as your anaesthetic. So fentanyl really blunts the effect of laryngoscopy on the intracranial pressure. Ketamine basically anaesthetises the patient, is an analgesic. Rocuronium paralyses the patient. And the doses for that usually will be 3-2-1, so 3 mics per kilogram, 2 milligrams per kilogram of ketamine and 1 of rocuronium. If they're very hemodynamically affected, then you'll use 1-1-1. If their blood pressure is really low, you might go 1-to-1, so just 1 of ketamine and 1 of rock. And if they've got no blood pressure, you might just use rocuronium. But let's not worry about that detail too much. I just want to think about ketamine just because it's a bit of a pet subject of mine. For many years, whenever we did an anaesthetic with ketamine, we were frowned upon and criticised by some people in the hospitals who said that ketamine was contraindicated due to surges in intracranial pressure. But if we look at the pathophysiology of head injury and how ketamine works, perhaps that's not entirely true. The other thing that we should say is the other choices of anaesthetic agents. So propofol will undoubtedly cause a drop in blood pressure. Thiopentone, again, almost certainly will. And etomidate, there are concerns about effect on the adrenal axis and so on. So ketamine just seems like the best agent that we have. But if you think about the pathophysiology of head injury, bit geeky stuff, just humour me for a few slides. Head injury increases the concentration of extracellular excitatory amino acids, which stimulate glutamate receptors, especially the NMDA ones, and those cause an influx of calcium into the cells. When your calcium goes into your cells, you activate some enzymes which cause breakdown of things which cause neuronal death, and you activate phospholipase A2, which causes release of your free fatty acids, which go on to do a few things that increases vascular permeability and cause vasoconstriction, so you get brain swelling and also not enough blood going to those areas because of the vasoconstriction. The raised intracellular calcium also causes the mitochondria to dysfunction, so they don't use as much oxygen, which flips them to an anaerobic pathway, and use the acidosis that will go with that. So in effect, raised intracellular calcium, which is an effect of the NMDA receptors being stimulated, has lots and lots of negative effects. We also need to be aware that severe head injury causes induction of a proto-oncogene called CFOS, which plays an important role in neuronal damage. That's also partially regulated by NMDA receptors. So if we just break that down into sort of simple terms, head injury stimulates your glutamate receptors, turns on CFOS, it causes neuronal death, vascular permeability, and acidosis. So all these bad things happen when you get a brain injury. Now, interestingly, ketamine blocks the NMDA receptor. So whilst it's not 100%, ketamine takes that out, and that stops a lot of these negative effects. So whilst people were concerned about a surge in intracranial pressure from ketamine, it actually has a massively positive effect on reducing all of these negative things that happen. So it is neuroprotective to a degree. So if we just pull together and get back to the basics, by doing the basics really well, you will minimize secondary brain injury, and therefore you will improve the outcome for your patients. And those basic things are opening an airway, giving oxygen and optimizing ventilation, stopping and reducing bleeding, keeping them head up, keep a collar loose or omitted, and keep them comfortable to give pain relief. Those basic things will save lives, will improve outcomes. Dead easy to do. So any questions? I will come off my screen sharing thing if I can. Excellent. So does anybody have any questions or anything you want to discuss a bit more? What was the basics thing I mentioned earlier? So Basics is a national organisation. It's the British Association for Immediate Care that oversees or overarches all immediate care schemes up and down the country. So Basics as a national organisation, it does a lot of things in terms of representing schemes at a national level. So things like we've had an impact on blue light legislation when you can use that. We have representation at different groups and organisations around the country. So the AAGBI, who are looking at the pre-hospital anaesthetic guidance, we have representation on that group. We have links into the driver training group, which impacts on blue light driving, and so on and so on. There's lots and lots of things that we work on. But at a more local level, most areas have got a Basics type scheme, an immediate care scheme. In Yorkshire, it's just called YAS Basics. A lot of areas have got really jazzy acronyms, but yeah, in Yorkshire we haven't. We're still YAS Basics. And what that does, that's a group of, at the moment, about 16 or 17 volunteer individuals who are all doctors with appropriate training and experience. We've just recruited some paramedics as well, actually. But these people, when they're available and on call, they will just be able to go out from home in their own cars. They've had blue light training and experience, so they can respond from home in their own cars to go out to serious incidents and support the ambulance service. So yeah, that's what Basics is really. So it's a really good organisation, and it does provide a lot of good care for patients. So I forget the exact figures, but I'm just trying to think. I think I did 3 thoracotomies last year as Basics, and probably about 12 or 15 RSIs, anaesthetics, and obviously there's a cohort of us. So so yeah, we provide a lot of good care, I think, to patients. Does that answer the question about Basics? Okay, so Ellis, I think, has asked what's the consequence of the BP being too high in brain injury, and what actually causes a raised blood pressure. So the raised blood pressure is often caused by loss of the autoregulation. So it's partly loss of the autoregulation, but also as the intracranial pressure goes up, the body tries to keep up the map by putting the blood pressure up. So it'll recognize the intracranial pressure has gone up and it will push the blood pressure up to try to maintain that cerebral perfusion pressure. So that's in the first instance. And often that can get linked in with a bradycardia as well as part of a Cushing's triad, but you often don't see that. You often just see the high blood pressure. Yes, so it's part of the body's response trying to keep the cerebral perfusion pressure going. And what's the consequence of blood pressure being too high? The main thing with that is if you've got an area of bleeding around the brain that might be starting to tamponade or something, but as the blood pressure goes higher, you're just squeezing more and more blood into that, so you're going to make the bleed bigger. So that will cause that raise in intracranial pressure to go higher, which links to all the stuff that we've said. So yeah, getting that balance of your blood pressure is really important. So yeah, trying to shove in an endotracheal tube in somebody without any drugs will cause a big surge in the blood pressure and it'll make that worse. So yeah, hopefully that answers that. Is that okay, Alice? Does that answer it? Okay, hopefully that's okay. Jessica's asked that you can get squashing of the optic nerve causing the fixated pupil. Can you get cranial nerve involvement of other nerves, or is it usually just that one? To be honest, it's usually just that one because of the path that it takes along the bottom of the brain and near the uncus. So yeah, that's the most commonly involved cranial nerve that you'll see. We don't sort of routinely look for involvement of other cranial nerves because they're so unreliable. That's the main one that we'd look for. Hannah said, yep, it answered the question about basics. That's great, thank you. Ellis said yes as well. What's the indications of doing thoracotomies and RSI pre-hospital as opposed to taking to the ED ASAP? Excellent, good question. I can go on for hours about this. So RSI, basically you for somebody with a severe head injury or ventilatory problem, they're the two main ones. Or humanitarian concerns if someone is just completely mangled. Then if you want to get them anaesthetized as quickly as possible. So if you're 2 minutes from LGI and you can get them there safely, it will be quicker to put a pre-alert call in, put them in the back of the ambulance and go. And that tube will be in quicker than if we mess around on scene, setting up our kit dump, drawing up our drugs, all that sort of stuff. But if you're further away and it's going to be quicker to put them to sleep and then take them in, then that is in a way, getting that tube in is the definitive intervention, because that is when you start to control the CO2 and the oxygen and start to minimize that secondary brain injury. So I would say the indication is if you can safely get that in quicker than take them to hospital and get it done there, that would make me want to put them to sleep. So for example, there was a job last week that I went out to that was, probably about an hour's drive from hospital, but it was kind of, about an hour for me to get there as well. So we arranged a rendezvous point about half an hour from hospital. So I met them in a hotel car park. All sounds a bit dodgy. And the ambulance came there. We did the anaesthetic and then we carried on to hospital. So it's just about starting that neuroprotective strategies as soon as you can. And I think sometimes RSIs are, people expect you to do them all the time, but we don't have to, because you need to remember the risks that come along with them. So if you can't get the tube in, or if you drop the oxygen, or if you drop the blood pressure, there are risks. So again, it would depend a little bit on the patient, how badly do they need the RSI, what's the experience level of the team that I'm with, and we balance those kind of things. In terms of thoracotomy, I suppose to come back to RSI as well, it would depend a little bit on my threshold for somebody with a head injury who's a little bit agitated but probably manageable. The threshold for that is very different to somebody, again, like my patient last week, with an airway that's full of blood that we're really struggling to manage and struggling to ventilate. That there's a more critical, that needs to happen, versus this one, which is a kind of bit of a luxury. So to balance that. Thoracotomies are interesting. So thoracotomy, the indication for pre-hospital thoracotomy, there's a few of them, but it's basically you think they've got a tamponade. It's the main indication, cardiac tamponade. So that obviously is blood in the pericardial sac that surrounds the heart. And as you get more and more bleeding into there, the pressure builds up and it stops the heart expanding during diastole, which means you can't get any blood in. And if you can't get blood in, you can't pump any blood out. So your cardiac output drops and they go into cardiac arrest. So essentially, you're going to have a penetrating wound somewhere that can get into the heart. So usually talking chest or upper abdomen. There will usually be a single penetrating wound, and they should have had less than 15 minutes from the loss of vital signs to get in hand on the heart. So if you get to a patient and it was half an hour, 45 minutes ago, that's not really indicated. So we used to say that if you can get the patient to hospital within 15 minutes of them arresting, go to hospital and get it done there. But when you look at a lot of the survival data, it drops off as an exponential curve. So every minute that you wait, the chance of a good outcome drops off dramatically. So now we would very much say that if you've got an appropriately trained and experienced team and you've got the indications, so single penetrating stab wound, etc., we would do it pre-hospital. They're relatively rare because thankfully we still don't have that many stabbings, but the numbers are going up and up. So yeah, they do happen, and we're looking more and more at training people to do them. So as I could go on, I'm just skimming the top of the subject there, but hopefully that answers. And Jessica's asked, sorry if it was mentioned before, and for all the questions. No, don't apologise. It's great to have questions. What's the difference between a basics doctor and a HEMS doctor? Do the same sort of interventions, or can HEMS do more? Is it just because they transfer faster? I've never seen a basics before on scene or mentioned, etc. You may well have seen basics on scene and not realised it, because they tend to be under the radar a bit more. They don't wear bright orange jumpsuits and stuff like that. So I'm not sure. I suppose the other thing is, if you guys are Hull and East Yorkshire, there's not so many basics doctors out there. There's 3 that live around Hull. There's 1 that lives up near, I want to say Hessel or something, but anyway, up that way. The biggest cluster we've got is around West Yorkshire and now South Yorkshire. In terms of what they can do, it's really variable. So HEMS, at the moment, HEMS don't always have a doctor on. So sometimes it's a double paramedic crew, or a paramedic and an ECA. So there's not always a doctor on. If there is a doctor on, then sometimes those doctors are basics doctors as well. So there's exactly the same skill set. And a lot of the basics doctors are HEMS doctors or have been HEMS doctors in the past. So the skill set we would bring is exactly the same. So yeah, HEMS is much more high profile. Everybody sees the helicopter, sees the orange jumpsuits and recognises what it is. If I turn up as a basics doctor, I may well be wearing an ambulance uniform. So I'll be wearing exactly the same green as the ambulance staff. So it isn't as recognisable that basics are there, if you see what I mean. There are also things like there's the West Yorkshire Medic Response Team, which has doctors on Friday and Saturday nights. And there's also now it's being called Merit, but it's a critical care team in a car that responds out of Leeds, but will cover anywhere in Yorkshire that we need to get to. And again, those doctors don't wear bright orange jumpsuits, but they will bring exactly the same skill set as HEMS. In fact, at the moment, because on there we carry blood and FFP, which HEMS don't, they just carry blood. At the moment, we have a slightly bigger skill set on the critical care car, but that would change come April because we're going to get FFP back onto HEMS. So yeah, so in short, yeah, not all basics doctors will do RSIs and thoracotomies, but most will. So yeah, I wouldn't want to say they're always exactly the same, but pretty much they are. What's the difference between basics and HEMS? Yeah, so HEMS, you have to be a consultant to be on HEMS. Basics, you have to be ST4 or above with appropriate training and experience in immediate care, which means most of them are consultants. And the other question was, is it that HEMS can transport faster? So yes, they can, but the vast majority of the time we don't fly patients. So when I was with HEMS, we didn't fly patients a lot of the time, because particularly with the bigger aircraft, you have to land it. There's legal requirements about how big the site has to be that you can land in. And because there was a slightly bigger aircraft, it meant that a lot of the time you had to land in a field or a park, which may be a bit of distance from the job. So you would end up having to get a lift or have to walk half a mile or something like that to get to the job. So then if you have to load a patient into an ambulance, load all the monitoring on, do all the stuff, then drive to the helicopter, then offload the patient, get all the monitoring off, carry them across the field, put them in the back of the helicopter, transfer them from the monitoring they're on onto the helicopter's monitoring. And by the time you've done all that, you can be to hospital. So a lot of the time, even if HEMS do attend the patients, and even if they're traveling with them, a lot of the time they'll go in the back of the ambulance. So HEMS is really useful for getting the team to the patient. And yes, sometimes if it's in the middle of rural North Yorkshire or something, they may well be able to fly. Or if they can land right next to a job, they can fly. But a lot of time they're going by road. So yeah, so they're there. So you may well have seen basics doctors and not realised. And people only work as a HEMS doctor for so long or for a maximum term. So it's no, there's no fixed term to it. So like I said, I was involved for about 18 years. At the moment, the employment, the way it's done is doctors are seconded for a 2-year period. And at the end of that 2-year period, they will have to reapply for the job. But when we started with a paid team on HEMS on 2016, and pretty much even though people were reapplying for their jobs every 2 years, we kept pretty much the same team. And I think the advantages of that, it means that if, so all of you guys in a few years, if you've been through your training and your HEMS or your FEM program, etc., it means that you'll be eligible to apply for jobs when that 2-year finishes. If it's just sort of dead man's shoes, if everybody's in full-time contracts and that's it, there'll be no window for new people to come and get involved. So I think that was one of the advantages of the 2-year secondment. Having said that, things are changing at HEMS, the way that people are being employed. So as I understand it, the next round will be another 2-year secondment, but potentially after that, it will be longer fixed-term posts. But there's that kind of employment thing about the way people have choose to sort out the secondments, but there's no maximum length of time you can work as a HEMS doctor. I know people worry about sometimes the psychological impact of the work, which the HEMS team do and see all the time, but that's not a consideration that says you can only do it for 5 years or whatever it might be. Yeah, so I'm rambling, but hopefully that's helpful. Like I say, we could talk for a lot longer about this, but are we okay for time? It's 8:05. Everybody all right? Time? Yeah.
No, that's fantastic.
So do you have to be a consultant or ST4 in FEM to be a basics or HEMS doctor, or can it be in anaesthetics or emergency medicine? So for HEMS, the criteria for Yorkshire at the moment was you had to be a consultant, and it didn't say what specialty, but you had to have 5 years immediate care experience of some sort. You had to have kind of a proven track record of delivering pre-hospital anaesthesia. You had to have trained at least in thoracotomy and that kind of stuff. So it does kind of limit it to A&E anaesthetics, but it's not an actual prerequisite. And I certainly know of surgeons that look to do it, even paediatricians, and there are some GPs that have done HEMS work up and down the country and still do. Actually, I know of GPs that do it. So yes, it's traditionally emergency medicine and anaesthetics, but there's no reason why it can't be other specialties, as long as those specialties can go away and get the training to allow them to demonstrate equivalence. So as long as they can get the experience of doing the anaesthetics and doing the surgical procedures and have a mechanism for maintaining those, then there's no reason why it can't be another specialty. Having said that, the best way, or maybe not the best way, but certainly the easiest way probably, is to become a FEM trainee. Because then if you be a FEM trainee, you'll come off the end. If you pass your exams, you'll get the fellowship in immediate medical care and you'll get a CCT in FEM. So in effect, you'll be a consultant in FEM, and that's possibly the easiest way to get a FEM job. There are ways of getting similar. You can sit the fellowship in immediate medical care, and you can get recognition as a consultant through other means, even without being a FEM trainee. But it's probably a little bit more straightforward as a FEM trainee. And to be a FEM trainee, unfortunately, at the moment, you have to be either A&E or anaesthetics. So again, I'm rambling a long way around, but the other thing that you find is up and down the country, there's more and more HEMS and ground-based critical care teams offering fellowships to people, which won't be a formal FEM training program, so it won't give you the CCT, but it will give you the same opportunities in terms of getting the experience, getting some of the workplace-based assessments done, completing your portfolio, and that will then allow you to get your certificate of eligibility to sit the FIMC. So yeah, so being A&E or anaesthetics is the best way to go and do FEM and to get your thing. But what I would say to people is pre-hospital care it's unlikely to be your full-time career. There's one or two people that have done that, and they tend to go and work for different services around the country on different days of the week. But most services won't employ full-time FEM people. So your day job specialty is going to be really important. That's your bread and butter. That's what pays the mortgage. That's what you would fall back to if you got an injury or something, so couldn't do pre-hospital care. So I've had some people that have said, well, great, I'm going to do A&E then so that I can do pre-hospital care. I hate A&E, but I'm going to do it anyway. And that's just kind of crazy, because that's your bread and butter. So I think if you desperately wanted to be a paediatrician, or you wanted to be a vascular surgeon, or you wanted to be an orthopod or whatever, go and do that. And there are ways to make it work to get into pre-hospital care. So that's HEMS. Outside of Yorkshire, you don't necessarily have to be a consultant. In some areas you do, in some areas you don't. Some areas will take on clinical fellows and other people. So there are opportunities for non-consultants, but a lot of the time people are using that non-consultant time to build up the experience to allow them to then go off and be a really good HEMS doctor. In terms of basics, it's variable around the country, different schemes and what they want from their basics responders. In Yorkshire, we took a view that because we now have critical care paramedics and HEMS paramedics and heart paramedics, etc., they've all got a lot of extended skills. So they can use midazolam and ketamine and calcium and magnesium, and they can sedate, and they can do amputations and chest drains and whatever else. Actually, if you're going to deploy a basics responder to that job, you're putting that responder at risk from driving on blue lights, you're putting the public at risk. So there needs to be a benefit from that person going. And that's why we said that, with every respect, an F1 or an F2 turning out probably isn't going to add very much to the care that's already going to be there. So that's why we said ST4 or above, which is kind of obviously registrar level or above, with appropriate training and experience. So in Yorkshire, that's where the West Yorkshire Medic Response Team comes in, because people are eligible to apply for that. And we have a selection day once a year where people can come as a CT1, and then they can spend a few years getting supervised practice on shifts with pre-hospital consultants. They can work through a sign-off portfolio, etc. And then that's the way that most people in Yorkshire will get their experience. So yeah, so kind of the ladder in Yorkshire really is HEMS or ground-based critical care team, basics, West Yorkshire Medic Response Team, and then below that is the things that you guys do. So things like pre-hospital care programs, things like being CFRs, things like working for Central Ambulance, etc. That is all an awesome foundation, because one of my thoughts is that being a pre-hospital care doctor, it isn't just about turning up, doing an anaesthetic and go to hospital. We need to have a much broader understanding of the ambulance service and pre-hospital care. So the more experience we can get through, like I said, being a CFR or event medicine or whatever it might be, it sets that really solid foundation. So as you start building up, you've just got a really strong foundation to build off. So that's kind of the ladder in Yorkshire. In terms of specialties, you have to be in basics in Yorkshire. Again, there's no specialty designated. So we've just taken on a paediatrician, for example. But what we stipulate is you have to have, like I say, training and experience. You have to work in an acute care specialty, and you have to have a mechanism for maintaining those skills. So, for example, a surgeon might not actually ever go to A&E and see a patient. They'll just have a patient put on a plate for them with a CT diagnosis or something. So that person would need to have a mechanism for working in A&E to see undifferentiated patients and get that experience, for example. Again, I'm rambling. I could go on, but I'll stop there. Does that answer the question, Jessica? Hopefully. Lovely. Is there anything else?
Thank you.
Fantastic. Anybody like to ask anything else? No, excellent. Yeah, you're welcome, Jessica. That's cool. I mean, feel free, if anybody's got any more questions that they want to ask but don't want to ask on this group, feel free to email me. I think Jake and Caroline have got my email address, so feel free to share that with people. And yeah, hope that was useful. Thanks for inviting me. Thanks for having me along. Yeah.
Thank you